Good morning. At the outset, I would like to thank Dr. Prabhu, Professor Prabhu, Dr. Karthi, and all the office bearers of Tamil Nadu AOI for waiting for this talk. As you know, Stapes surgery is the 5 functional surgery in the field of medicine. Becoming a very good Stapes surgeon that demands a lot of commitment, skill development, and a lot of enthusiasm. In the forthcoming slides, I would like to share my experience of 30 years of experience of doing Stapes surgery. The factors affecting outcomes in Stapes surgery can be divided into pre-operative and operative factors. The most important thing I feel is the pre-operative counseling. And you have to assess what is called the involvement of the inner ear. When you go to the literature, you can see that 30-50% of involvement of round window there. And among these 0.5 to 1% of total obliteration of round window is in autosclerosis. Mobility of the rest of the ossicle, that's also very much important. You can have coexisting malleus fixation and fixation of the anterior manual ligament. 5 to 6% is the incidence in autosclerosis. And of course, the single most important factor is a meticulous and precise surgical technique, which decides the outcome of the Stapes surgery. There are a number of studies in the literature. You go there, a lot of studies comparing the senior registrar and the junior registrar, professor, consultant. That all these studies shows that stapedectomy is a highly scientific but technically challenging procedure. And several studies are documented that clinical outcomes are dependent on surgical expertise. The preoperative counseling should, first of all, the doctor should give, surgeon should give a realistic outcome to the patient. And before counseling the patient, the surgeon should realistically assess his surgical skill, whether he is able to perform surgery in a very good way. According to that, he should tailor the counseling session and counsel the patient very well. And the salient points that should include the usage of hearing aid, how much hearing improvement he can guarantee after surgery, about the tinnitus, post-op vertigo, taste disturbance, and of course the chances of hearing loss after surgery. And go to the literature, there is 0.6 to 5% is the chance of sensory neural hearing loss at varying degree. And in this, 1 to 2% can have a total hearing loss after a Stapes surgery. And you should always tell the patient that there's a chance that you can lose the hearing. And approaches and anesthesia. People, I do all cases, more than 800 cases I have done last about 19 years. I have done local anesthesia. Very rarely I do go for general anesthesia. You can do endomeatal. Majority of cases have endomeatal approaches. And if the canal is narrow, you can go for endoral or post-oral approaches. You can use local anesthesia, that is very good. You can do the testing of the hearing cooperatively. GA in non-cooperative patients also you can use. And speculum, you can use a classical speculum. I use always a self-retaining endoral speculum, the to-market speculum, so that I can use both hands in doing the surgery. Canal incision always same. 1 centimeter incision process in 6 o'clock controllable position. Elevation of the flap is 1 degree is very important. You should not tear the flap. And smaller temporometer flaps produces inadequate exposure and bone removal will be badly affected. And bigger flaps, especially after injection and everything, you inject into the flap becomes bulky. And so the visualization will be less in case of a bigger flap. And reduces the visibility and freedom of instrumentation. And the next important step is a curative. That is a very important step. People use, I use always a curative, house cure, a very good house cure I use. Always it should be along the parallel to the course of the facial nerve and no contact. Make sure that no contact with the ossicles or tympanoid flap. And the complications are injury to the product tympanic, facial nerve. Sometimes it can produce including dislocation that can also produce, especially if you are not doing it under microscope. Endoscopic stapedic people are practicing. The depth perception is not that good, so there's a chance that you can dislocate all these ingratosacral joint. That's what I mean, malleolus joint. How much you should expose? This is also you should expose. You see the whole long process of incus and till the pyramid. Underexposure, difficulty in fenestra creation and piston placement. Overexposure produces chance of retraction pocket formation. And the caudate tympani is the main culprit. And I will borrow the words of Dr. Vijayendra. He said that dealing caudate tympani is just like taking mother-in-law with your hand. So always be careful about the caudate tympani. The best way is you just negotiate the caudate tympani at the point of entry into the middle ear. This place is inferior. Never stretch it. Stretching can produce damage and taste disturbance. And go to the literature. All literature say that about 40 to 60% of taste disturbance after the surgery, and all these taste disturbance recovers within 1 year time, and after 1 year patient will not notice that. And if you are planning for a contralateral stapedectomy, you should note down in your case sheet that I have done this thing to the caudate tympani, or the taste is disturbed. So if it is a bilateral stapedectomy, if you are doing the same thing, disturbing the caudate tympani, patient will have a severe taste disturbance. Checking the mobility of the ossicles, always open this. First of all, you have to move the malleus, and you see that the incus is moving or not. And second thing is you have to move the incus. See the mobility, but stapedial mobility is okay. But finally, you will see the stapediovestibular joint. The stapes is fixed, that is not moving. This is how you have to test the mobility of the ossicle. As I told, there's 5 to 6% of coexisting malleolar fixation with the sclerosis. Reverse stapedectomy, it is always safe to go for reverse stapedectomy because early fixation, you can get a control hold, and the mechanical can be reduced after removal against the sector. That can occur fracture and that can be avoided by it gives additional stability because of the tendon attachment. Stapedius tendon cut or preserve. Almost all cases I have cut the tendon of stapedius and you just dislocate it and cut the tendon. And there are studies that by Vittorio Quality, he published it. He said that there are advantages the tendon preservation stapedectomy, saying that it maintains the vascularity of the lenticular process. And second thing is prevents slippage of the prosthesis, future slippage of the prosthesis. And these are the advantages, and it helps in the preservation of hearing in a noisy environment. But the other studies are there, comparative study, there is no difference, but there are no difference between the preservation technique and the tendon sparing technique. Okay. And the ideal piston for a stapedectomy should be long, and the shaft should be a raw area so that the membrane formation around shaft will be promoted, and the loop area should have a memory, and if possible, it should be a malleable prosthesis that can help you giving a very good attachment to the incus. I have used Teflon piston and tough wire piston. I have used in difficult cases. Tough wire means the axis of the incus is not exactly in the middle of the foot plate or it laterally placed with some complicated anatomy where the facial nerve is bulging and everything. I used wire piston. So the effect of piston diameter in primary stapes surgery. You go to the literature, it says that 0.6 millimeter diameter. There is a study there. A multi-centric study says that 0.6 millimeter is far better than 0.4 millimeter. Actually, there is no difference at all. But there are some other studies also that shows that 0.4 millimeter gives advantage in high frequency hearing. And the complications 0.4 and 0.6, no difference. Measurement of distance. Always I used to measure the distance, even though I know that either is 4.25 or 4.5. Always measure it because the medullary is the one which the indentation everything that makes very small changes in the dimensions of the ossicles, alignment of ossicles. So it is always to measure the distance from the surface of the stapes to the foot plate and make sure that your piston should be exactly 0.2 to 0.25 millimeter inside the endosteum of the vestibule. If it is more than that, that is going to touch the saccule here, that will produce vestibular disturbance. By placing the fenestra posteriorly, we have an additional advantage that this is going to be close to the away from the sacking. Fenestra, I have used conventional instruments in the initial phase of my surgery. Then Skeeter is the number 2. Both these instruments can nearly autosclerosis produce a mechanical trauma to the foot plate, and sometimes it can cause early subluxation of the foot plate. And for that, the laser is the best one. One short laser produces a real fenestra, and you can vaporize the suprasacral node with the laser. But I haven't used it. And the size of the fenestra, I always use 0.8 millimeter fenestra, and occasional fenestra is always in the posterior half of the foot plate. And fracturing, I always use the conventional instruments, put a pick in the neck of the stapes and fracture it towards the promontory. I use powered instrument, drill and everything. Laser vaporization is also excellent results. And this is how you use a skeeter for removal of the stapes superstructure. You just drill it very easy now, very easy. And you can drill it and remove the posterior crust very well. Anterior crust is very, the anterior crust is thinner than the posterior crust, so it can be removed with a 45-degree angle bit. And crimping. Always use the Teflon piston. You have to crimp. And there are crimping and degradational. You go to the, I always crimp the position, not too tightly or not too loosely. There should not be any prime. After fitting the prosthesis, you should move the malleus and see if there is a delay in the movement of the piston. That means that the piston is not too tight. You have to make it tight. So what you have to do is crimping. There are a lot of different studies. Crimping attachment gives about 4 to 7 decibels of gain if you grip it very nicely. And if it is too tight, that can give rise to necrosis of the long process of fingers. So it should not be too tight or too loose. And sealing the fenestra, always use the fenestra, fat and everything I have used. That gives excellent results. And some difficult situations, I will go through that. Or like facial now, the first situation you can go ahead with the surgery. The second situation, you can see the facial is 50% is taut, and there is no bone that is lying over the foot plate area. Even in this case also, you can go ahead with surgery, you give a good decongestion and retract it superiorly, or you just give close to the promontory and the foot plate, you give a control hold, you can put a wire piston, without touching the fascia. This is one of the complicated. Immediate facial palsy, always due to that, because I do local anesthesia because of the complication of the local anesthesia. And delayed facial palsy, I had one patient, they did 2 patients with delayed facial palsy. That is the activation of the herpes. So that's also kept in mind. Before taking the history also, you have to ask this. You can have a delayed facial, which usually recovers with the antiviral or antisteroid treatment. And accidental or partial or total removal of the foot plate, that is also possible. Mechanical trauma, I told you, while removing the foot plate, superstructure, if this is possible, especially in this type of foot plate, the big foot plate is possible. All these cases, what you have to do is you have to keep a fascia or a perichondrium or the foot plate region. Then you can put the piston. You can have very good hearing and make sure that the patient is on labyrinth sedative. Patient can have a little bit of a time. Biscuit foot plate or obliterated foot plate, disorder situations, you have to always don't tunnel the foot plate. You have to saucerize the whole foot plate and you create a fenestra and put a piston that is going to give you an excellent result. You can do that. You have to drill, you have to wait on, keep on drilling, and you make sure that your piston is sufficiently long that go into the endosteum. Some special situations, when you open, you can, especially in revision cases, you see that the ingus is crossed and you have to do a malleovestibuloplexy. You have to use a special piston like this. This is long back, these are the arch, this type of piston, and you have to measure it from the foot plate and connect it to the undersurface of the malleus. And the results are reasonably fair, but not as good as an inguinal-vestibuloplexy. And the results of Stapes surgery in 2006 to 2025, I had around 808 years I have operated in the period of study from 2006 to 2025. Primary Stapes surgery I have done in 787 cases, revision 21 cases. And I have performed monthly, immediately after a month, 3 months, 6 months, and 1 year. And every year we have repeated audiogram. And 98% of the patients had a reasonably good gap, less than 20 decibel. Out of that, 94% had less than 10 dB gap. 1.62% had about 13-14 patients, not more than 20 dB. And 0.38%, 3 patients out of this lost hearing. And I would like to discuss about that patient, lost hearing. One patient is an advocate, and he was practicing in the High Court of Kerala. He lost hearing on the 5th or 7th day after that. He was so panicky, he was very famous. So I opened it up. It is a respiratory granuloma, removed the piston. He was got a rescue hearing. Now he is able to use hearing aid that year. And another patient, after 1 month period, he was head load worker, heavy smoker. He went for a weightlifting. Suddenly he got giddiness. He lost hearing. When he came back, another patient also lost hearing immediately. I don't know the reason. I just checked it. The patient had giddiness, but it is a mixed loss. It is not a pure conductive loss. It was a mixed loss. My observation: operating in mixed hearing loss should be extra careful. The chances of sensor involved getting hearing loss is more. So that's about. We are coming up with a long-term follow-up. In this primary Stapes surgery, including vestibular pexy, I had 774 cases. Manual vestibular pexy 12 cases. One case, there was no ossicles. Manual sandal was necrosed. Fingers was not there. In that case, I took challenge. That was also another advocate. So I have operated that lady, done a fenestra creation, and I had done a coda vestibular pexy. I connected with the coda and augmented the region with this thing. And we are coming in the long-term follow-up of these cases. We are able to raise 418 cases. Longest follow-up is 18 years. Okay. So this is the results. You can see 2011 I have operated. This is 2025 audiogram. Another patient, we can 2008 I have operated. And this is 2025. These are the results. And including revision cases, including vestibular 19 cases, manual vestibular 2 cases, complete vestibular cases. In this case, I want to discuss the case of bilateral CS1 with otosclerosis. Left ear was closed, membrane profession was closed by another surgeon. Right ear I have operated. This is the post-op audiogram. During right ear tympanoplasty, I noticed that there is Stapes fixation. He needs stapedectomy later. He was taken for the left ear, other surgeon operated. I saw that this is the picture. I am not playing the video. This is the Stapes and this is the Lucas part. No malleus handle, nothing. Only head was there. The demanding of so what I have decided, what I have done is, this is the I created fenestra. I put a tough wire piston, titanium wire piston. Coda was intact. I connected with the coda. Then over the coda, I have placed a small piece of cartilage from the head to the posterior canal wall. I have because the titanium is a metal piece which not come in contact with the tympanic membrane, and the tympanic and the cartilage piece I have kept and augmented and protected the caudal impact. Yes. And this is the post-operative appearance. Recently, this was operated in 2019. And this is the video otoscopy in last month. You can see the cartilage here. You can see the cartilage is working very well. This is the audiogram immediately after 3 months surgery, and this is the audiogram now. I mean last month, or after about 19. So 6 years later, this audiogram. So I am going to operate her next week, the other year. She's coming for surgery. So you have to take some chance and try to give better result to the patient. So revision stapedectomy always 3 reasons: simple the piston. Number 1, short piston. Number 3, necrosis of the long process of injuries. All these things. This is another case, short piston. I have just went through obliterative otosclerosis, took out the piston, created a fenestra, and then a Stapes connection. You go to the literature, you can see this is you can see in the middle here the Teflon piston is lying there. So you go to the results of the revision Stapes in the literature, almost 70 to 80% patient can have a good bone gap less than 20 dB. You can have a revision surgery. And the take-home message is proper selection of patient constant practice are the main successful surgery. And proper size and position of piston and proper length of piston are very important successful surgery. And surgical skill and precision. I feel this is the most important thing and the main factors in good outcome of the Stapes surgery. Before ending, thank you all. Thank you, Tamil Nadu, Mohan